Welcome to another edition of Your Health Matters with Dr. Benjamin Bryant, Chief of Staff and General Surgeon at Conneaut Medical Center here in Conneaut, Ohio. Dr. Bryant, it's warm outside.
For a change.
You know, when we started doing this show together again, it was in November, December, and it was cold and snowy and icy. This is the way I like it.
Absolutely. Absolutely. Well, you know, we had a cool spring.
Yeah,
Pleasant.
we did.
But now summer's finally coming.
It's warmest it's been since, I guess, last August or September.
That's
so
right.
We'll take it. I know you have guests with you this morning.
Oh, my goodness sakes. We are very fortunate this morning. Dr. Tomasz Rogula is out here from Geauga. Very kind of Tom to come out. And one of his patients, Mike, you're going to have to help me with your last name.
Habina.
Habina.
Yes.
Mike Habina, who has very kindly come out all the way out here to Conneaut today. He's a patient of Dr. Rogula's. And we're going to be talking about some very important and very cutting-edge things that Dr. Rogula is bringing to university hospitals at Geauga, having to do with bariatric surgery and also what is evolving as another reason for these kinds of procedures. It's called metabolic surgery. Tom, thanks again for coming out. Could you kind of tell the public a little bit about your background and your interests?
Benjamin, thank you for inviting me. It's a great pleasure to be in the program here. I came from Poland in 2002 to the United States only to get training in bariatric surgery. So those days, bariatric surgery was mostly about losing weight. There was a weight loss surgery. I went through several trainings in New York, Pittsburgh, and my recent place was Cleveland Clinic, where we actually work very hard to study the mechanism, how weight loss can be translated into metabolic benefits, in particular improvement of type 2 diabetes. There is, as you mentioned, there is distinction between weight loss surgery and metabolic surgery. At some degree, these are the same operations or similar operations, but we're looking at different outcomes. For metabolic surgery, is mostly type 2 diabetes improvement.
Now, diabetes, we've covered this topic many times in these segments. I think perhaps our public may be a little bit more sophisticated than a lot of publics now because of the information that they've gotten. And people know that diabetes, and particularly diabetics know that diabetes is no joke, okay? It's something that, it's a kind of disease that carries with it several terrible kinds of complications, terrible effects on overall health and so on. And if there's a surgical procedure that can actually and demonstrably impact diabetes and improve diabetes, that's a very, very big deal. That's a huge public health issue. Okay?
Right. So the history of this, surgical treatment of diabetes comes back to late 80s, and doctors who are performing bariatric weight loss surgery, they observe some effect on diabetes. Initially, we thought this is the effect of not eating enough or eating less, but in the long term, like you are a very good example, the diabetes essentially completely resolved. So we did a lot of studies looking exactly what's going on with the intestinal hormones that are produced as the effect of this operation, and we found that some particular hormones might be involved in improvement of insulin control and improvement diabetes. But coming back to your question, some patients, they don't realize how dangerous and how difficult diabetes can be. The good example is patients with diabetes who are going through cardiac problems. Diabetes has been shown as one of the strongest risk factors for cardiovascular diseases.
And keep in mind, as we've mentioned, that heart attack is still the #1 killer in the United States, men and women.
Right, right. So there was studies done back in Europe in 80s and 90s. They looked at thousands of people who had diabetes and compared them with those who got resolved diabetes. And the #1 thing that improved is mortality risk improvement after metabolic surgery.
Now, what that means is that if you don't have the surgery, your chance of dying from the disease is a number. And after the surgery, your risk of dying from the disease is a lower number.
Correct. Exact numbers is about 40% reduction of
40%. That's almost half.
Right, of premature mortality from cardiovascular events.
I mean, everybody has heard the stories of here's a 60-year-old guy who dies of a heart attack.
Right.
60-year-old, and that, man, I mean, that's not rare. That happens all the time.
I had a patient I saw her yesterday, and she's coming to operate with me in mid-June. She's 38 years old. She had 2 heart attacks already. She had cardiac stents put on. Again, the #1 reason is uncontrolled diabetes. She's on about 100 units of insulin, lots of medications with no improvement at all.
So let this sink in a little bit. What we're hearing here is that the risk of heart attack, the #1 killer in this country, is strongly associated with diabetes, strongly, and that if the diabetes is eliminated, we're not talking about, and Tom will get into this, we're not talking about controlling it. We're talking about eliminating it, okay? If that's eliminated, then that risk is cut almost in half, almost in half. So this is enormous. This has enormous implications for the health of the population.
You know, I have a person that would like to have the surgery but has a fear. And what is the risk of having the surgery?
It's a very good question, and a very good reason that a lot of patients and doctors, they hesitate going through surgery. It's mostly because of in early days of developing this discipline, we've been learning from experience, but the major improvement has been done in late 90s when we start doing this laparoscopic kind.
And people should know that. Laparoscopically means the small incisions.
Yes. Yes, so it looks like gallbladder surgery or some other minor operations outside.
Okay.
But using laparoscopy, we reduce one big problem: wound infections and hernias. So that was a relatively common thing before, but now it's completely eliminated.
Does insurance cover these operations?
Yes.
They do?
Yes. So
Okay.
Medicare covers this
Okay.
quite well.
Okay.
Most of the private carriers, they also cover the operations. Some of them, they have special requirements, like pre-surgical weight loss, that you actually went through this for several months.
No, Dr. Bryant, I think since we've been doing these interviews for about 8 years now, and since the time we started, during that period of time, actually the insurance companies came around and said, if it's going to improve your health, it's beneficial for us to take care of this.
Yeah, and to be perfectly honest, Pat, I mean, let's speak plainly here. Being insurance companies, it's beneficial to their bottom line.
Sure.
It's beneficial to their bottom line because the sorts of costs that insurance companies incur if these problems are not treated is much higher than the cost of the treatment.
There you are. Mm-hmm.
Okay. So that should help people understand why the insurance companies will do this.
Okay.
So you've seen the complication rate go down since laparoscopy.
In percentage, those complications are around 1 to 2%. So it's very comparable with most of the surgical procedures.
I'm just curious, how long does one of these operations normally last? How long does it take?
Right. Typically, it's about an hour and a half.
That's it?
Yes, about 90 minutes in the operating room, and about 2 to 3 days of recovery in the hospital.
Wow.
So it's relatively, most patients, they can walk same day.
I think my sister-in-law had it, if she could walk that day, she could go home that night, and I believe she did. But she has to eat very low doses of food, very soft stuff, for a while.
For a while.
Yeah.
Well, that's amazing. I didn't realize that it had become so refined. What we're talking about is a fairly significant altering of the gastrointestinal tract that's done in a procedure that carries basically the same risks as a gallbladder operation, and a minimal impact on a patient's life in terms of recovery and so on. So people who have diabetes, people who have tried to lose weight and are not able to lose weight, really need to talk with somebody like Dr. Rogula, who really understands all of these issues, so that they can learn, gosh, that fear is not justified. It's just simply not justified.
Let me ask Mike a question here, Michael. Did you do this on your own?
Yes, I did.
You just had enough, and
I at my peak weight was 360,
okay.
and that was May of last year, of 2015. I started the program with UH in May, and in June I had a heart attack, and that made me want to get going more.
Okay.
And I had to go to through 6 months of the program first, where you go 4 months you go to a seminar with a bunch of other people, and then the next 2 months is one-on-one with a dietitian and Dr. Rogula. And after the 6 months, December was my 6th month. January 14th, I had the surgery.
Of this year?
Of 2016, right?
Yeah, January of this year.
And you've lost how much?
92 pounds.
In that short a time?
Yep. Well, since in May of last year, I was 360. From that point to yesterday, it was 92 pounds.
Congratulations.
Thank you.
That's wonderful.
Wow.
That's great.
Tom, does everybody follow the same track as Mike did? I mean, in terms of the preoperative and the seminars and so on?
Right, pretty much. So the program that we have is quite comprehensive and very multidisciplinary. So we have nutrition, psychologists, internal medicine, cardiologists. We all work as a team to help patients getting ready for this big change. It requires some modifications in eating habits, eating less different things, more protein, and we have very detailed teaching how to live with this operation. Most patients, they follow your track. In terms of weight loss, it's very, very typical. Also in terms of controlling type 2 diabetes. We see patients like Papa yourself that actually leave hospital with no insulin at all. They were on insulin for years before, and typically 2 or 3 days after surgery, the insulin is completely cut off.
That's amazing.
It's almost immediate effect. So
Think about that, folks.
right. So it seems to be independent from weight loss. Controlling diabetes starts very early on, right after operation, and then weight loss makes it more stable and durable.
What about the aftermath? Obviously, your appearance has changed, and you're thinner, and you look a lot different than you did before. Is that part of the program in getting them ready to go into that new life?
Excellent question.
Yeah, you have to go through a psychiatric evaluation before you even start.
Is that right?
Yes. And I had to go to Cleveland or UH in Cleveland to a psychiatrist, and very extensive. I was there
To
for
make
like
sure
an
you
hour
could
and a half.
handle it.
Yes. Yes.
Wow.
See, and this shouldn't be seen as punitive. This should be seen as supportive.
Right.
See, this is a big deal. You want to talk about a life-changing event.
Sure.
This is a life-changing event. And what UH is committed to is your success. They want this to work for you. They want the metabolic effects of the surgery. They want the weight loss effects of the surgery. And they also want you to feel comfortable and supported and with plenty of people to talk to and resources you can have to make sure that you feel comfortable every step of the way. That's what that's really all about, is to get you ready and make sure you succeed. Now,
What about when you got done with this? I heard you mention that you came off a lot of meds.
I was on 4 diabetic medications, yes. And it took about a month and a half to, well, the doctor, my endocrinologist said, well, he took me off of 3 of them right away. And the 4th one was an injection. And he said, once your prescription is done, don't get any more. And I didn't. And my blood sugar has been running around 90 every day, between 90 and 95, where before, when I was in the hospital, it was 400 and 500.
No kidding.
Yeah, so I'm so happy. It really helped.
off all diabetic medications.
Yes.
It's amazing.
That is really unbelievable. That is really unbelievable.
And you will continue to lose weight?
Oh, I'm hoping so, yes.
Yeah.
Yeah, I'm like a year ago, or in May of last year, I was wearing a size 54 pants. These are size 40, and they're getting a little bit too big. So that's 14 inches set of
You're beating me now. Wow, that's
My wife
amazing.
bought me a set of a pair of pants that are 36s, and that's my incentive. They're hanging on my dresser.
Good for you. That's great. I'm just curious too, Michael, is like for your eating habits, what would you eat normally now?
No, but protein. They knock you. They eat protein all the time. So I have a lot of fish, chicken, turkey. Turkey is fantastic protein. Cheese, egg whites.
What about beef?
Steaks. I love steaks.
You can have that.
Oh yeah.
Okay.
Yeah, that's good protein. But the thing is I'll get a nice Delmonico, and I can only eat half. You know?
Sure.
So I put the other half in a box, take it home, and I'll eat it later on.
There's nothing wrong with that. That's great. Great story.
That's really pretty amazing.
Mhm.
So let's say that we have someone who is hearing this and they have diabetes and they're compliant, but their sugars, sometimes they escape control. Their hemoglobin A1C isn't really where it should be, but they're not super heavy. Okay, they're not super heavy. You could say BMI 35 maybe or so. All right. Would a person like that benefit metabolically from this operation?
It's a great question, Benjamin. So scientists they put together a recommendation or guidelines, which was actually published yesterday in London, UK. So there was a meeting with endocrinologists from all over the world, surgeons, internal medicine doctors, and in conclusion, they provided the guidelines specifically indicating benefits of this operation for patients with lower body mass index. So, for example, patients with body mass index 35, which typically means less than 100 pounds overweight, they will be very beneficial. Even lower than 35, we did several operations on people relatively low body mass index.
Really?
It really works very well. Insurance might not cover this because standard of care these days is body mass over 35.
Well, it always takes them a little while to catch up, the insurance companies. But once they understand, it does. But once they understand that they are insuring somebody with diabetes who's most likely no longer going to have diabetes, they'll come around. I'm sure they will.
Now, in many countries, I traveled quite a lot to teach these operations. So, for example, in India and China, people are very sensitive to being even slightly overweight and then responds with very poorly controlled diabetes right away. So doctors in Asia, they do this operation on relatively non-obese patients with very good outcomes in terms of controlling diabetes.
What if somebody come in that would be my size and they want to lose the belly and all that sort of stuff? Would that be a part of this or not? Would that be some other kind of surgery or some other kind of?
It's a very similar operation.
It is?
We do two type of operations. One is more advanced, one is a little bit less invasive. The weight loss effect and diabetes, they come together. So we offer almost the same operation for patients without diabetes, but being overweight or obese,
Okay.
and those with diabetes. In fact, we do, I think, more and more patients with diabetes as a main indication these days. Some patients who are overweight, they can try to control their weight with better eating habits and exercising, with some good outcomes sometimes. Most of them they unfortunately fail losing weight after several attempts. In our group of patients, on average, they go through at least 10 to 15 different diets before they end up with us.
Okay.
Now, if you have diabetes, it's a very different story, because it's the fat that is accumulated in your stomach makes this diabetes very poorly controlled through complicated mechanisms like insulin resistance and other complicated things. So it becomes very, very difficult to control diabetes just with diet and exercise. There's lots of studies which clearly show no benefits in terms of medical control of diabetes. Some of the medications that you probably are on, they actually make people gaining weight. So there's like a vicious circle situation. When diabetes is poorly controlled, doctors, they add more medications, and some of them, they make people gaining weight, and gaining weight makes controlling diabetes even worse.
Sure.
So surgery comes into action and breaks that vicious circle and let people escape from that situation.
Okay. Amazing stuff, Doc.
Oh, gosh. I mean, this is revolutionary.
Yeah.
This really is revolutionary.
You and I have talked about this for years, about the importance of getting diabetes under control. And I learned a lot today, but I had a friend that had diabetes and it put a lot, it was very heavy, and ended up having a stroke, ended up losing his foot, and it was a sad thing to watch that he finally lost his life, because he didn't control it, and maybe that's all he would have needed is this surgery to help him get through it.
Well, one of the things that people are, I'm hoping, picking up on, this conference that happened in London, okay, these are very serious people. And the recommendations that come out of a conference like that have to be based on the evidence. They will not make that kind of a recommendation unless the evidence is there. And evidence means reproducible, okay? We do this, we expect this outcome. So that they can look the patient in the eye and say, based on the experience that we have, you can expect this outcome. You have to be able to reproduce the results before it can be endorsed like that. And it was endorsed like that. So most likely this gentleman that you knew, Pat, would have had a completely different trajectory through life if he had had
I see that now.
surgery early.
Yeah.
None of that stuff would have happened.
Sad
That's the importance of what we're talking about here today.
Can I ask you, Mike, how old you are?
I'm 61.
61. So you were like 60 when you started the program.
Yes.
Okay. And you feel pretty darn good.
Oh, I got so much more energy now.
Good for you.
Absolutely.
I would like to shift gears here just a little bit.
Sure.
I'm going to bring up something that Doctor and I have talked about a little bit. Lots and lots and lots and lots of people get ultrasounds. of their abdomens. And it's very frequent that when the doctor talks to the patient about the results of the ultrasound, the patient is told, well, you've got a lot of extra fat in your liver. A lot of extra fat. It's called, fancy word is hepatic steatosis. It just means you got more fat in your liver. And maybe you can shed some light on this, doctor, but sometimes the fat in the liver doesn't really cause too much of a problem. And sometimes, a lot of times, it causes big problems. It injures the liver cells, and it's a progressive injury. And my understanding is that extra fat in the liver is approaching the #1 reason why people have liver transplants in this country. See, it's no joke. I mean, it can progress to the point where you have liver failure, and believe me, that's a neighborhood you don't want to visit. That's a very, very tough diagnosis, very, very sick and fragile people, okay? And my understanding from having briefly talked about this with you in the past is that metabolic surgery, bariatric surgery can have a beneficial effect on the extra fat in the liver. Is that true?
Yes, so there's very strong scientific evidence, and I was actually involved in some of the studies where we took a sample of the liver at the time of operation. We sent it for analysis, and we checked this again about 2 years after. So there is, in some of these patients, there's complete resolution of that condition that you mentioned. Wow. That saves the liver and saves patients' life. If it's not very advanced yet, it might be completely reversed to normal situation. It seems like the fat in the liver causes some, as you mentioned, in very chronic and very aggressive reaction, almost like inflammation. If it's going for years, it makes progressive changes, sometimes into cirrhosis, even hepatic cancer sometimes. We see patients with this condition sometimes also.
That makes sense. I mean, that chronic injury and the body trying to accommodate it, there's plenty of opportunity for the reparative process to go haywire.
I guess I don't understand. So you're taking the movement here, but it affects the liver. It helps
Through the bloodstream.
Oh, okay.
Through the bloodstream. Yeah. Yeah.
Okay.
But again, this is also a very big deal because there really has been no therapy for hepatic steatosis, extra fat in the liver. There's really been no reliable therapy for it, and we've watched as it has progressed and progressed through the population until now. It's a more frequent indication for liver transplant than alcohol, more frequent than hepatitis C. I mean, it's coming up as #1 reason why people need liver transplants. And hepatic steatosis, extra fat in the liver, is very, very common. I mean, it's all over the place. So if you're somebody who has been found to have that, and your liver function, your liver enzymes have been checked and they're not normal, they're sort of up, that is a pretty good indicator that the fat is injuring your liver. This is a chronic process. Unless something is done to correct it, it's going to keep on going, which places you at risk for these terrible complications. So this is another reason. And is it an independent indication for the procedure yet, or is it in progress, or how is that going?
It's part of that group of diseases we call the metabolic syndrome. It's all of those diseases, they connected to each other. So hepatic liver disease, type 2 diabetes, hypercholesterol, and increased blood pressure. These are all connected, and the main thing is obesity. So hepatic liver disease might be part of the problem. Sometimes we do operations for patients who already have quite advanced hepatic liver disease. Some of them, unfortunately, they already have liver completely damaged. So we do this still for them to get prepared for liver transplantation, to protect the new liver
To protect the new liver.
from having the same problem.
All right, let me give you an example all right, patient comes in, BMI of 34, okay? And have been found to have extra fat in the liver, and their liver enzymes are abnormal, okay? So this is somebody who's not super heavy, who we know has extra fat in the liver, and we know that the liver is being damaged. Would that be an appropriate candidate for this procedure? Would they be able to get it done?
No, we need to do some studies, make sure the patient is, the risks of the benefit of the operation are not too high. So we typically send those patients to hepatologists to assess those risks. There's a special scale we use. Typically, those patients, they go through a little bit less invasive operations. We call it sleeve gastrectomy,
Right.
which might not influence so much the anatomy. Just in the case they need a liver transplant in the future, we don't want to change the anatomy
Right,
too
sure.
much.
Right, I understand that.
And also, we want to protect some nutrients absorption. So that type of operation makes absorption of most nutrients normal.
Right.
So we don't want to change that, of course. But definitely, this is a very good option for this kind of patient.
So if you do a sleeve gastrectomy, and we won't get too technical here, but that is a bona fide weight loss operation. But in this case, sleeve gastrectomy, you do see the impact of that on the hepatic steatosis.
Yes, yes, definitely. There are studies that clearly show benefits of sleeve gastrectomy for this condition.
Wow. That's spectacular. That really is. I mean, this is pretty revolutionary stuff. All right, so patient is hearing this, wants to get involved. Obviously, you know, I've had several patients come to see you with different indications along these lines. How does a patient make contact with you? I mean, Dr. Rogula's phone number, you'll be seeing it during this presentation. They're putting it so you can see his phone number. What do? Do they go to their primary care doctor? Can they call your office directly if they're interested in more information? They certainly can contact mine because I have the information. I have the ability to get you in to see Dr. Rogula. I can get you started with the introductory seminar through UH. Your primary care doctor probably can too. I'm sure they can too. But can people contact you directly?
Yes, there's a phone number we can see on the screen. We try to make this as easy as possible, so people call that number, and we coordinate the entire program. So they need to go through certain steps. The teaching is the first step. You go to seminar.
How I got started on that was, it was an online video questionnaire. I did that online, sent it in, and they contacted me for our first appointments.
So first thing is to make sure the patient have knowledge about what we do. Second, we check the insurance. We have insurance specialists who review the insurance coverage, and sometimes we negotiate with insurance to make sure we get coverage. And they go through psychology, nutrition, cardiology clearance. We also do quite extensive blood work and x-rays and other studies as needed.
But they can contact you directly. They don't necessarily need a referral.
Correct. Correct.
That's very important, folks. I mean, you're hearing this. You can tell your family members about it. Tell your friends what's going on here. And you see the number, and you can call. You don't have to wait. You can just pick up the phone and call.
And your office is located
In Geauga,
in Geauga, which is not that far away.
No, you don't have to go all the way to Cleveland.
Right.
You don't have to drive downtown.
Yeah. That's good.
Yeah, that's great. Well, gosh, this is. I hope people will let this sink in. The import of this. What medications do we have here? These are the diabetic medications that Mike was on
Right.
before he had his operation. Some of these might ring a few bells. What do we have here? Victoza, metformin, glimepiride, Actos, okay? And now off all of them.
All of them. Yeah, I put on there when each one came off. I started this in August of 2011, that Victoza, and 8 weeks post-op, it was gone. The metformin, it was removed it was like 2 or 3 weeks post-op. Glimepiride,
Yeah.
it was 4 weeks, and then at 2 weeks of post-op was the Actos was gone. So I did that in a reverse thing, but
The take-home message is, I mean, people out there are gonna, oh, I recognize that medicine, oh, I'm on that, oh, I recognize that medicine. And what kind of a world is it when you don't take them anymore, and your blood sugar's 90?
yeah, it's a good
Okay.
feeling.
Yeah, all right. Well, folks, listen, if you have any questions or any interest in discussing this further, please call Dr. Rogula's office. UH does make it extremely easy for you. One phone call and then everything just kind of happens. They make it, because we understand the impact of this on people's lives. And what our interest is to get this kind of very cutting-edge approaches to these problems out to the public, and to have somebody who is advanced in this field as Dr. Rogula is to come out here and talk to our public is just, well, we really thank you for coming out. We really appreciate it. And Mike, thank you so much for sharing your story.
No
An
problem.
amazing story.
Thank you.
And to come out here and talk to people who are could really be able to benefit from this.
It works.
It's just a real public service. We really appreciate it.
Excellent show today, Dr. Bryant.
Unbelievable.
Very
Really,
good.
really.
Remember, your health matters. We'll be back in a couple of weeks with another subject, so stay tuned to 6 and 19.
One other thing, I gotta slip in, I'm obligated before we go
Okay.
completely off the subject. We have talked about how UH Conneaut plagiarized my show name and have this program that's called Health Matters, a great program where a physician is available on a Wednesday each month, 6 p.m. here in the Brown Room, where people can come in and just in a relaxed, informal session, just talk to the doctor directly. And the next one is coming up the second Wednesday in June at 6 p.m. here in the boardroom. And they've actually asked me to handle this one. So I'm going to be here talking about men's health issues. And I particularly want to talk to women are, of course, welcome to come to it. But I'm going to be talking about prostate issues among other issues.
And it's free.
And it is free. It is free. Just call the hospital and let them know, or you can probably just show up. Doesn't cost anything, and just want to make sure that you're aware that that's going to be happening. Tom, thanks again.
Thank you.
Really appreciate your coming.
Thank you.